So welcome everyone to our third of the breast webinars available from Providence Saint John, the Margie Petersen Breast Center. Today we're going to be talking a little bit about intraoperative radiation therapy for breast cancer, and that sometimes less can actually be the best. We'd like to thank our sponsors, the Irene Dunn Guild, who has been generous in funding these webinars for us, and along with the Ken Johnson family in memory of Joan Brierton Johnson. And especially for this webinar, we were very fortunate to have ZOF, a subsidiary of ICAD, to sponsor our webinar today. I'm your moderator today. I'm Janie Grumley. I'm the director of the Comprehensive Breast Program at the Margie Petersen Breast Center. I'm a surgical oncologist and associate professor of surgical oncology at the John Wayne Cancer Institute. We are so very, very excited to have Dr. Robert Woolman present for us today. He is the medical director of the Vasek Pollock Radiation Oncology Department here at Providence Saint John's. He's an assistant professor of radiation oncology at the John Wayne Cancer Institute. He did all of his training out east, but then came to his senses and moved out west and has been out here ever since, enjoying the sunshine with us. So we're so very lucky to have him here to tell us a little bit more about intraoperative radiation therapy. Dr. Woolman.
Thank you very much, Dr. Grumley. Also, thank you everyone who's participating today in the webinar. It's really nice to be here. And of course, thanks again to our sponsors. I think from the title of the presentation, sometimes less can be best. If you have a very good working computer, you could see from my hair, I'm a very firm believer that less can be best. It's a little odd to tell a joke when you're doing a webinar because you can't hear all the hysterical laughing on the other end. But I'll just assume that's the case and move on to what we're really here to discuss today is intraoperative radiation therapy for early breast cancer treatment. And it's something we feel really excited about here at the John Wayne and St. John's program. It's something we've been doing now for about 3-ish years since Dr. Grumley came and joined us and taught us a new way of taking care of something that we had taken care of for many years before. So it's something we're really excited about, and hopefully you will be too when you hear about it. So let's go back in history and talk about the evolution of radiation therapy for the treatment of early breast cancer. If you go back prior to the 70s and through most of the 70s, all women were treated with a mastectomy. The radical mastectomy was the main treatment for breast cancer. And it was invented around 1900, I believe in New York City, by a doctor named Halsted. If he wasn't the one that invented it, he's certainly the one that wrote the most about it. And it was the way all breast cancer was treated for 70 years. And it actually began in France, that a lot of people started to question, why are we taking off the whole breast? Very often the cancer is much smaller than the whole breast. And the radical mastectomy had been the only solution for many years until people started to question that and say, can't we do something less? Well, one of the things that made doctors nervous about not doing a radical mastectomy was that when we took off the breast and looked under a microscope at the breast tissue, even though there was a tumor in one part of the breast, it was very common to find cancer cells in other parts of the breast. So if you only removed the tumor, you could be leaving a lot of cancer cells behind. And that's when people came up with this concept of removing the tumor with surgery and treating the rest of the breast with radiation, because surgery is a really good treatment for a large lump of tumor, and radiation is a really good treatment when there's just a few cells of the tumor left. So this concept of doing not a mastectomy, but a lumpectomy with whole breast radiation therapy was brought up and then tested. And the tests were something called randomized clinical trials. And it was really quite amazing. And in the 1970s and 1980s, the second bullet point on this slide, a lot of research was done by really heroic women and their doctors who were willing to try something new. And the concept of a randomized clinical trial was pretty new in those days, where a coin toss would literally decide whether you got a lumpectomy with whole breast radiation or a mastectomy. And there were many of these studies done in the United States, done in Europe, done in Canada, that showed and really proved beyond a shadow of a doubt that this new concept of doing a lumpectomy with whole breast radiation therapy was equal to a mastectomy. And the whole breast radiation therapy was basically 6 weeks of treatment, 10 minutes a day, Monday through Friday, where the women would come in after they'd had their lumpectomy and recovered from their lumpectomy. They would get 6 weeks of daily radiation treatments. Treatments only took a few minutes. The side effects were not too bad. The breast would get pretty red and women would get pretty tired as the 6 weeks wore on. And then there were some other rare side effects that could happen from that radiation. There were very rare chances of getting heart disease and getting some lung disease. And this was many, many years ago, and the treatment technology we had for delivering radiation wasn't all that great. But most women, other than getting the skin reaction and feeling tired, had relatively few problems associated with that whole breast radiation. But it really took a long time. And that, 6 weeks out of people's days, even if it's only 10 minutes a day, is a real problem for people trying to live their normal lives and work and take care of their families, but also for women to get to the radiation department. There are a lot of places in the world where radiation departments aren't right around the corner. And if you live in rural Europe, Canada, or the United States, it could be a real challenge. So a lot of research was done in the 1990s to try and figure out ways to make this 6 weeks less onerous for women. And a lot of research, particularly in Canada and Europe, where they have fewer radiation machines and departments and fewer spots, they really had a major economic impetus for studying ways to shorten radiation. So they showed that if you gave a little bit more each day for 3 to 4 weeks, you could do just as good with the same amount of side effects as the whole breast radiation in 6 weeks was. So that was the next step in this kind of evolution of doing more with less. I don't want to say get away, because you were doing just as good a job, but you could save women a whole lot of time of coming in for the daily radiation treatments by just giving it slightly more each day for 3 to 4 weeks. So that's called whole breast radiation therapy short course, is probably the simplest name for it. And that's pretty much where things stood until the 2000s. And by the 2000s, people were saying, all right, we still think 3 to 4 weeks of radiation is too much. And something else had happened over these ensuing 3 decades. We started doing mammography a lot more. We started doing a lot of other early detection interventions. So the cancers, which were really big, if you go back to when we first started doing cancer and lumpectomy and radiation, or mastectomy in the 70s, the cancers were mostly found by palpating the breast, or a doctor felt it in an office, or a woman felt it when she felt her breast. And by the 2000s, cancers were much, much, much smaller and found by mammogram, and women were much more attuned with screening, and doctors were much more attuned with finding cancer early. So a lot of studies were done to try and treat not the whole breast, because in those days, in the 2000s, when they did that same thing, they looked at the breast under a microscope. Because we were finding tumors that were much smaller, we were seeing far less cancer in other parts of the breast. So people said, why do we have to treat the whole breast? Just like we decided we didn't have to remove the whole breast 30 years ago, maybe we could give radiation just to part of the breast. And when you decrease the amount of tissue you're giving radiation to, you can also increase the amount you give without having more side effects and finish quicker. So there were a lot of studies, again, these randomized clinical trials, where many, many heroic patients agreed to get less than whole breast radiation and only get partial breast radiation. And it was really shown, not for everyone, but as you could see in red on this bullet point, in women who are good candidates, which is one of those weird medical terms we like to use. We're not running for any election, but in women who meet certain criteria, we call them good candidates. Women who were good candidates, which generally meant, we'll talk more about that as we go, which generally meant small tumors without involved lymph nodes, you could do just as good by treating part of the breast as treating the whole breast. So people were pretty happy with this because now we've gone from a whole mastectomy to 6 weeks of radiation to 4 weeks of radiation to the whole breast. And now we're giving radiation only to the part of the breast. So there wasn't nearly as much skin reaction. There was less fatigue. Women were done in 1 week. But there were a lot of pioneers who were saying we could still do better than this. Maybe we could get it down to 0 weeks of radiation by using this new technology called intraoperative radiation, where instead of using machines that shoot radiation beams from the outside of the body to the inside of the body, let's give radiation while the patient is having her lumpectomy and bring a new machine to the operating room where we could give radiation right at the same time just to the partial breast or even just to the cavity where the tumor just came out of. And then it would all be done in one treatment. And that's called intraoperative radiation therapy. And it's really been shown in a bunch of studies, we're going to look at one in a little while, to be the equivalent of all the previous treatments that we talked about, the whole breast radiation, the partial breast radiation, short course, but doing it all in one in women who are good candidates for that. So why did we treat the whole breast? Well, historically, in the 70s, breast cancer was much bigger than what we see now. And we've gotten much smaller tumors, as I said before, by awareness and by doing mammography. We also knew, as I said, that the laboratory evaluation in the old days showed cancer in other parts of the breast. The lymph nodes were also involved. If the lymph nodes are involved, it implies we're not talking about a tumor that just stayed in the breast. It's spread, not throughout the body, but off into the lymph nodes, which means you can't just give radiation to a relatively small area, but you need to give more comprehensive treatment to the chest wall and to the breast. And also in those days, chemo and hormonal therapies were not as effective as they are today. But these days, we find most cancers much smaller. Imaging, mammography, and MRI is much better at telling us that there's no cancer in other parts of the breast. Many studies have been performed that show even without any radiation at all, when the cancer comes back, it doesn't come back in other parts of the breast. It comes back at the same spot the original tumor is, and our chemo and hormonal therapies are much better. So all of these things have made the utility of radiation to the rest of the breast not necessary. So to give you some idea of what we're talking about in terms of volume, I wanted to take some pictures here to show you. On the left side, you can see whole breast radiation, and these are CAT scans, and this is how we look at, even though you can't really see radiation, how we look at where the doses of radiation go by these colored curves. And you could see the breast, and you're looking at the breast from several different angles on a CAT scan in those images. The whole breast is treated with that green and yellow, red colors, which are meant to show where the radiation is hitting. And you could see it hits all along the chest wall, hits the whole breast. It hits some of the axilla or armpit when you're doing whole breast radiation therapy. Intraoperative precision radiation therapy, as you could see on the right, just treats that cavity. And what you're seeing there is a balloon inside a lumpectomy cavity on a CAT scan. And you could see that you're treating a far lesser area of the breast than you would be with the whole breast radiation. And that's why, as I said earlier, the less volume of tissue that you're actually giving radiation to, the bigger the dose you could give at once without causing any damage. You also can't cause any damage because you're keeping the radiation very far from the lungs and the heart when you're doing it with a special precise machine in the operating room rather than a machine that's shooting beams from the outside of the body. You have much more control of where the radiation goes, and your target is much smaller. So you can actually give the same amount of radiation that we give with external beams over 4 or 6 weeks, but you're only treating the small area. You give it all in one treatment. And that's the beauty of intraoperative radiation. So I just wanted to show you on a calendar how long radiation following a lumpectomy takes. In the original green boxes, you could see you'd be busy getting daily radiation treatments through all of February and most of March, 6 weeks of 30 radiation treatments. And then we found out in the blue box that you could do hypofractionated, which just means shorter course whole breast radiation, but it would still take up most of February and most of other months. The partial breast radiation, if you look at January, was only a week of treatment, but it was actually usually given twice a day. So some people disliked coming in twice a day for 5 days. That some ways is harder than once a day for 20 days. But really, as you could see from January 5th, if you get it all in one day, it's taking the least time out of patients' lives to get their radiation treatment. So earlier I talked about good candidates, something we all have on our mind for the next couple of weeks here. This is a different type of candidacy. To be a good candidate to have intraoperative radiation, you have to be peri or postmenopausal. There's not been much research on women who are really premenopausal. It may be just as good, and there's a lot of research going on right now, but because of probably some historical reasons that breast cancer in younger women was often felt to be more aggressive, a lot of people felt uncomfortable in premenopausal women doing intraoperative radiation or partial breast radiation. So a lot of them were excluded from those studies. It may be, and probably is, just as good in women who are premenopausal, but we all think we need a little more research to say they're good candidates for this procedure. And postmenopausal are generally the first thing we think of as good candidates. Also tumors that are smaller, tumors that get much bigger than 3.5 centimeters, or tumors that have negative margins are probably tumors that the radiation we give just inside the cavity, because it doesn't penetrate the whole breast, isn't going to be enough radiation. And the other thing, as I said before, lymph nodes. If the lymph nodes are involved, then we feel, and we know from research, that we have to give radiation to a much bigger part of the chest wall and the breast than just the cavity. So these are the main things that lead women to be good candidates. And one of the things, if you're thinking about this, you'll notice it's easy to tell if somebody's peri or postmenopausal by asking them. It's also pretty easy to tell if their tumors are bigger or smaller than a certain size based on the mammograms and based on the MRIs. But the two things that I have here in italics, negative margins and lymph node negative, those are things that we can guess sort of sometimes before surgery, but we don't always know, or we never know 100% if the margins will be negative or the lymph nodes will be negative until after surgery. So we'll come back to that because that is part of the thinking process. But mostly we look at the beginning, are the tumors small enough to do the intraoperative radiation? Are the women not premenopausal? And do the lymph nodes appear to be negative? And do we think we'll be able to get negative margins? If we don't think all three of these points will be achievable, then we don't think intraoperative radiation is a good thing to do. So what if we find out, and we don't find this out until after surgery, because the pathologist has to look at the margins and the lymph nodes. So if a woman looks like she's otherwise a good candidate for the intraoperative radiation, is interested in doing the procedure, we go ahead and do it. And we check the lymph nodes and we check the margins. And then we find out from the pathologist a couple of days after we've done the intraoperative radiation and after we've done the surgery that the lymph nodes are negative or positive, or the margins are negative or positive. 80 to 90% of the time, the lymph nodes are negative and the margins are negative, which means that's it. No need for any further radiation. And if you look at all the patients with breast cancer who are probably good candidates for the procedure based on their age, based on the size we think the tumor is, it's probably around 40, maybe even as high as 50% of all women may end up looking like good candidates. And of that 50 to 40%, 80 to 90% will be done after the intraoperative radiation. But if they're not, then we sometimes have to recommend a short course of the external beam radiation that we talked about before. And the good news is we haven't wasted anything, because the intraoperative radiation cuts off a week of that external radiation. So instead of 4 weeks, because we've already done some radiation, we only need 3 weeks of radiation. So it's not the end of the world, but most people won't need that further radiation treatment. So let's talk a bit about the pros and cons of intraoperative radiation therapy. Well, mostly the pros are pretty obvious from things we've talked about already. Time, no need out of your daily day for 3 to 6 weeks of daily external beam radiation treatments. Women love that. Distance, as we said a little bit earlier, many women don't live near radiation centers. And actually many women, because of that, if they don't live near a radiation center and nobody's doing intraoperative radiation in their hospitals, they actually choose a mastectomy over breast preservation just because they can't get to the radiation. Side effects, there's no fatigue, no skin redness, itching, or peeling, which is obviously a great thing. Money. Giving just one treatment in the operating room is a whole lot cheaper to the healthcare system than giving 6 weeks or 3 weeks of radiation with a machine. It involves less other machinery, technologists, physicists. It's really a great savings to the healthcare system. We'll talk about that. I'm emphasizing healthcare system because something that may be good for the overall healthcare system can sometimes hurt individual doctors or hospitals. And we're going to talk about that a little bit. Safety. Some of the research, can you just go back? Thanks. Safety. Even though I told you external beam radiation is quite safe and it's changed a lot over the last 50 years we've been doing it, in the old days, there was about a 2 or 3% chance of having heart or lung or secondary cancer complications from heart or lung, 2 or 3%. Secondary cancer complications is more like 1 in several thousand. But there were some complications, very rare, from the external beam radiation therapy when you give it to the whole breast. With intraoperative radiation, the radiation only goes to the tumor cavity, not the rest of the breast and chest wall. So there's, even though it's small, the risk of other complications now with external beam radiation, it's even smaller with intraoperative radiation. And then, another major pro now is COVID. Not having to come in, even though we know it's very safe to come to hospitals these days. We work in hospitals every day, and there's been really no major evidence of COVID spreading to doctors and nurses that work at our hospital. If patients can avoid coming into the hospital here in California, obviously, I guess this is going beyond California, this webinar, but in California, people drive themselves, but in a lot of places, they have to take public transportation. And even in California, people take public transportation. But if we can avoid it all during COVID, especially with our elderly patients, and we can do it all the one time they have to come to the hospital, that's a huge advantage right now. So now let's go to the next slide and talk about, well, what are the cons? Doesn't this all sound so fantastic? I don't think I've said one bad thing about intraoperative radiation, except that some people, if they turn out to have positive lymph nodes, have to have extra radiation. But that's not really a con. These are the, quote, cons. People have said, and you'll hear people who are either skeptics or naysayers of intraoperative radiation, it's too new. You don't have really good data that tells you it's as good as the external beam radiation we've been doing for years. Well, that's true. We don't have 40-year data but we have a really good study that we're going to look at in a little bit that was just published. That's 12-year follow-up of a randomized trial that compares this intraoperative radiation to whole breast radiation. And we'll talk about the results, but basically I'll ruin the punchline. It's just as good. Wound complications. Some reports with some of the initial technologies doing intraoperative radiation said there may be higher rates of minor wound issues. We've done hundreds of cases here at St. John's over the last few years, and we haven't seen any increased wound complications or things called seromas. We've been thrilled that we don't see any skin reaction and any wound complications. A con, as I said, there are naysayers or skeptics of this technology. And I think the most important reason are the next two reasons why that's true. This is very disruptive to the way a lot of hospital and doctors are used to doing radiation therapy. It's often done not in the hospital. It's done at freestanding centers. If we go back in history, a lot of radiation was always done in hospitals, but patients didn't like coming to the hospital to get their radiation. So we built all these freestanding centers so healthy outpatients don't have to come into the hospital. And people have gotten used to that, just going to your local radiation center. Doctors have gotten used to just going to their local radiation center. So there aren't a lot of doctors at hospitals. We're really lucky at St. John's that we all work in the same roof, and it's really easy for us to do intraoperative radiation. But to a lot of other hospitals and doctors, this is hugely threatening the status quo or how things have been for many, many years. And then what I alluded to on the previous slide, money. Yes, it saves money for the system to do this one treatment, intraoperative radiation, but it actually takes a lot of money out of the pockets of radiation centers and hospitals that they've been used to, because right now it reimburses less and there's less need for external beam radiation. So when things are that disruptive to the status quo and can actually cost money, and you don't actually work in a hospital setting, it's very threatening to a lot of the doctors that aren't yet used to doing this. And that's one of the reasons that radiation, intraoperative radiation, isn't spreading like gangbusters, I think. And I think that probably very soon, once Medicare and other payers realize how much money this saves them, they're going to adjust how much they actually pay. So it's a better thing when we save money for the system, but when hospitals and doctors lose money, who gets to keep that money? A lot of times insurance companies. So it's a complicated thing, the economics of new things in medicine. So these aren't really cons of intraoperative radiation therapy, but they go a long way to explaining why it's not spreading as fast as it should and why maybe many of you are just hearing about it for the first time today. So how is it actually done? Well, if you look in the pictures on the left, first, Dr. Grumley or other surgeons remove the tumor. Then we put a balloon applicator. An applicator is just a fancy word for a way to apply the radiation. And we put the balloon into the lumpectomy cavity, and then it comes out through the incision in the skin. And we use an ultrasound to make sure that the balloon is filling the cavity and that we've got the right size and shape, and that the balloon isn't too close to the skin that it would burn the skin. And once we like all of that placement, then everybody else, the surgeon and the nurses, leave the operating room, and then me and the physicist attach this radiation machine, which you'll see on the right side of the screen, to that balloon. And that puts a little teeny source that we'll look at in a second into the center of the balloon, and that gives the radiation over about 8 to 10 minutes. The bigger the balloon, the bigger the cavity, the longer we have to be there while the radiation is being given. Don't worry about us. We're safe. We know what we're doing. We stand behind radioactive shields. And you should also not worry about the patient, because sometimes patients get worried. They're like, well, you're behind a shield. This must be really dangerous for me. Obviously, this doesn't happen when patients are asleep, but it's not dangerous. The reason we have to stand behind a shield is not because it's so much radiation. It's because if we got a little teeny bit of radiation every day for many years, it could be dangerous. But everybody else leaves the operating room just to keep everybody safe and sound, except for me, the physicist, and sometimes the anesthesiologist. We stand there while the radiation is being given, and then the radiation is removed, the balloon is removed, and the operation is finished. And what you see here on the right side of your screen is actually one of those balloons with the catheter attached to the machine. So that tube that's coming out of the white balloon and is attached to the machine is the catheter, and the little radioactive source goes down that catheter into the balloon and sits there for 8 to 10 minutes to give the dose of radiation. So here's that little radioactive device, or small electronic radioactive source. It's a really cool machine that gives a very nice dose of radiation to the cavity. And it's basically a mini light bulb, more or less, but it's a much higher energy than the light bulbs you have at home. It's actually the same energy of the X-ray machines that are used when you go to the dentist and get a dental X-ray. And it's kind of close to the same energy as what's done with a mammogram, but it's made really miniature so it could fit into that balloon and give the radiation very rapidly. It's a very slick radioactive source, which you could see is, pretty much the size of the pad of your index finger. So I told you earlier about the research that was just published, and this was actually published in the British Medical Journal, but an earlier version of this study was published, maybe 5 years ago. And there's another study that's just like this study. This was done throughout Europe and the United States. The other study was done more just in Europe. And they both did the same thing. They gave intraoperative radiation to half the patients and whole breast radiation to the other half the patients. Some of the patients, the ones who had positive lymph nodes or positive margins or other bad features, but not very many of them in the intraoperative groups, did get external beam radiation, as we talked about. So it's not all the patients that got IORT only got IORT. The radiation was adjusted, but almost all of them, 80 to 90% of them, just got the intraoperative radiation. And these are survival curves or recurrence curves that compare the patients who got the intraoperative radiation or the external beam radiation. And you would have to get a pretty good microscope or magnifying glass to see much separation of these curves out to 12 years. And that's how we tell. Separation of curves tells you whether there's a difference or not a difference. But as far as the local recurrence, which is the first, meaning the cancer comes back, we call it a local recurrence when it comes back in the breast. No real difference between target. Target means intraoperative radiation. That's the machine they use. And that's the pink line versus the blue line, which is external beam radiation therapy. Same with invasive cancer, local recurrence, or breast cancer free. Those top three tables really don't show any difference at all. None of them really show any statistical difference at all, except for one, which we'll get to in a second. So mastectomy-free survival means that the cancer didn't come back and a patient didn't have to have a mastectomy. Distant disease-free survival means that the cancer didn't spread. Again, no difference. The only one that there was any significant difference for is there appeared to be slightly improved non-breast cancer survival in patients who got target or got intraoperative radiation therapy, the pink line. And people think that may be due to a slightly higher risk of complications to the lungs or the heart. It's very small, if it's even true, and a lot of people don't even believe it's true. But if it is, it may be a big advantage to doing intraoperative radiation, very slightly smaller chance of dying of heart disease or lung disease. But the actual overall survival, which is the last panel, didn't show any real difference. So we feel this is a huge piece of information that we didn't have. And the people, as I said, there are a lot of people who are skeptical of this treatment or threatened by this treatment, whether it's from a dollars and cents point of view or whether it's just because people don't like to change what they're used to doing. Now we have a lot of long-term data that this is just as good. And remember, it's not that it's comparing just intraoperative radiation to whole breast radiation. It's comparing intraoperative radiation for the majority of women, plus some of them that need whole breast still get whole breast radiation, to women who only get whole breast radiation. So that sort of takes away one of the major cons, if you will, of this treatment, and hopefully will explain to more and more people why they should feel, as we do, that intraoperative radiation less is best for women who are really good candidates for the procedure. And I think that's my last slide. Well, except for a review slide, and again, a little funny slide that I can't hear you laughing, but I can see in the corner of my webinar, Dr. Grumley smiling. For many women with early breast cancer, less is more with intraoperative radiation therapy. We get the same breast cancer control. There's less side effects, less time getting the treatment, less cost, and possibly less deaths from other causes when we do this treatment. That's all I have to say. Let's move on to panel discussion and questions.
Thank you so much. That's a great review of kind of the last 100 years when it comes to radiation and breast cancer treatment. If anybody wants to reach us afterwards, we are on Instagram at MPBC Breasties or at the John Wayne Cancer. Our office number is 310-582-7100. And you can always reach out to us if you do have specific questions about IORT or your breast cancer care. We do have a couple questions for us from the panel, and it's not too late. If you do want to kind of enter more questions, feel free, but these are other ways in which you can connect with us. So if IORT is such a great treatment, why doesn't every hospital or clinic offer it?
Yeah, as we talked about during the discussion, it's a big game changer. It's a big disruptor. It's, you know, when Uber and Lyft came out, taxi drivers were scared to death about what are they going to do. Well, a lot of them moved over to become Uber and Lyft drivers, or they tried to fight it through regulations. In California, in fact, there's a big proposition that we're all kind of deciding to vote. So some of these things that change the status quo are a big challenge. And it seems like that shouldn't be the major thing that drives how quickly people adopt this, but it really is. If it's going to, until there's enough groundswell opinion and articles written about this and people attending webinars and the research gets more and more out there, the motivation is not to move to something that's going to make less revenue for your hospital and department and disrupt your daily work where you actually work, until the payers are forced to pay either more for this or less for the other form of radiation therapy, or there's more and more public demand for this treatment. And that's one of the main reasons we're doing this webinar, but also because we know it's got less side effects for patients. And so once you buy into it, then it becomes really easy to do, and you see less, you know, so much less side effects, so much happier women.
I think a large part is just, you know, interest amongst common minds, right? I mean, I brought this up as something that I'd like to do. And if Dr. Woolman wasn't excited, this wouldn't happen, or Dr. Chaikin. And I think it's, you know, I've looked at starting IORT at 2 separate places now. And the reason why I've come to those hospitals is because I think there are some like-minded physicians who are looking to do things better for the future. Is it more inconvenient? Absolutely, because we have to set apart we have to schedule it, and there's some legwork definitely associated. There's definitely cost. Part of what's so great about, you know, being at St. John's is that we do have the foundation support. You know, when we showed up and said we really want to try this new thing and we have to buy a machine and we have to put this program together, our foundation was so supportive in helping us do that. So I think we're all in the right place at the right time. And I don't think you get that at every single hospital. So we feel very, very fortunate to have that. Wouldn't you agree?
Definitely.
Yeah. The next question we have is, why isn't premenopausal women a good candidate for IORT?
Probably mostly lack of research, and you probably agree with me. I think we're just trying to be more cautious. When they first started this in the old days, not just the old days, when there was less awareness and less women doing breast self-examination. Young women tended to present with worse breast cancer than old women, and some still do, unfortunately, but they wouldn't be directed towards it. So we're probably going to be good candidates, whether they're premenopausal or postmenopausal. We just need more research on that.
Well, I think the candidacy is just, what the societies say, you are definitely a good person to have this, but there's lots of research. Like you said, even here at St. John's, we've got a clinical registry available so that we can follow patients, because we want to answer that question, is it better? But here we're offering it in patients who are 45 and older. And being 45, I'd like to think I'm not perimenopausal yet. But we are offering it to women as young as 45, and I'd love to see more data in the future. And being a research institute, it'd be very interesting to see if we can look at biology or the type of cancer they have as opposed to the age of the person who has the cancer when it comes to who's a good candidate.
What you say is that's something we're learning so much more about is age is just a number, whether it's at the high end or the low end. And if we could understand the cancer better, and rather than make, judgments at any age about judgments based on the cancer, not on people's age.
Right. So our next question is, can IORT be used in non-invasive breast cancer, DCIS?
Yes, it can be. It's something we do. And we think it's just as good. Every other research that's ever been done comparing breast cancer, whether it's DCIS or invasive breast cancer, the radiation results are pretty much the same. So the radiation may prevent different things, like invasive breast cancer is more dangerous, so preventing a recurrence is a bigger deal than preventing a recurrence in non-invasive breast cancer. But the amount of decrease of the recurrence that radiation provides with invasive and non-invasive is pretty much the same. They're just, again, a little bit like the younger patients. We need a little bit more research till everybody embraces that, but we think it's just as good for ductal carcinoma in situ.
Yeah, I think the initial kind of hesitation when it comes to ductal carcinoma in situ people have is the unpredictability in size and the risk of positive margins with DCIS, just because it's not something we can see and feel at the time of surgery. So I think surgeons might be a little nervous about doing, intraoperative because you need the clear margins. We do MRIs prior. If there's something that shows up on an MRI that can help us decipher how big it truly is, I think it adds a little bit to it. I recently published our experience from Seattle of 50 ductal carcinoma in situ patients, very low re-excision rate, especially if we're able to use oncoplastic techniques and the MRI and everything. So I think it's definitely something that can be done, and we are doing it, like you said, here at Providence. And I can't wait to, report our experiences from here, because I think the more we add to the literature, the more people will feel comfortable with using it in that situation. So how long does the IORT treatment itself take?
The IORT treatment, so once Dr. Grumley's finished doing the lumpectomy, preparing the cavity and putting in the balloon, probably
blame it on me.
for her to finish doing surgery.
Yeah.
Then preparing the cavity, doing the ultrasound probably takes about 5 to 10 minutes, and then delivering the radiation takes about 8 to 10 minutes. So probably adds to the whole surgical procedure, around 20, 25 minutes.
And it differs from machine to machine, right? So there's 3 different machines out there that delivers intraoperative radiation therapy. The one we've chosen, I think, is easy to use and delivers it in a short amount of time. But there are other machines that are a little bit more cumbersome, a little harder to dock and prepare the entire thing. And then the delivery time can be a little bit longer too. So it varies from machine to machine, depending on what they're using, right? All right, and then I think this is our last question. How long after treatment can someone return to work, back to normal life?
Well, the intraoperative radiation doesn't change that one bit. That there's
So
no.
now you're blaming me again. The surgical part of things.
That's a surgical answer.
Yeah, usually, I don't think people feel any different, at least our post-op patients, whether they have surgery alone versus surgery and radiation. I think most of what people are healing from and feeling after is the surgical healing, the anesthesia and all the other stuff. So I don't see people requiring any extra time for recovery. Most of our patients are up and walking around the day after surgery. They usually get back to work, depending on the work, sometimes sooner than a week. Some people will take a little extra time just because they're tired. Everybody's different, but nobody is kind of laying around debilitated or exhausted for long periods of time. Wouldn't you agree?
Yeah, and I was just going to say there are, as I said, some women, not every woman who has the intraoperative radiation, that's all the treatment they need. Some do need the external radiation, which you can do and work. It doesn't take away from your ability to work. We just need to get the patients here for a few minutes each day to do the radiation. So I've never really had anybody skip work because they needed some external radiation.
Yeah. We are in LA, so we should talk about IORT and implants. What do you think of them?
And I mean, external beam radiation can cause a lot of scar tissue for women with implants. And it can create, since if you usually women with implants have the cancer on one side and implants on both sides. And if you radiate one side and the other side, which didn't have the cancer, doesn't get any radiation, with external beam radiation, you very frequently get some scar tissue that forms called a capsulectomy can have to be done. That's where the surgeon takes out some of the scar tissue after that forms from radiation therapy to the whole breast. It can cause dysymmetry, so the two sides don't look the same because the radiation scar tissue can make the implant move a little bit. Intraoperative radiation doesn't do any of that. So intraoperative radiation for women who have, relatively small tumors and negative lymph nodes is really ideal in the implant setting.
Yeah, I would agree. Yeah. It's nice to have these options, and that's part of what I always tell patients, right? It's nice to have options, and this is another great option for us. All right. Oh, I think that was all of our questions. So thank you all for participating. We're so glad you were here with us, and thank you so much, Dr. Woolman. It was very informative, and hopefully that was helpful for those out there who are listening. And please tune in next week. It will be a little different. So not so much information, not so much education, but just more about what patients have gone through, how they feel about their treatment, and some of the questions they kind of wish they had answers to before they had their diagnosis or while they were going through their diagnosis. We hope that will be helpful for all of you out there. So please tune back in and join us for next week. Thank you.
Thank you. Thanks, sponsors, and thanks for everyone who participated.